Hello, friends. I'm back. It's been a month since I started this lecture series. Today is the 1st of February, and but lecture number 24 because in between I didn't take classes to accommodate the Karnataka College of Obstetrics and Gynecology lectures and other CMEs and webinars of my colleagues and friends. So today I have picked up this topic because once there was a question in the MD exams, PRAKI, and many students were wondering what is PRAKI. They have heard of PRACHI, but not PRAKI. So it's pregnancy-related acute kidney injury. So I thought this is a very, very important topic. It can come in a short note, it can come as a long question, and it's a very, very practical problem. Every practicing gynecologist also should know how to recognize this, how to prevent it, and as well as how to manage it should they have a case of acute kidney injury that is related to pregnancy. So what I want to tell you today is that this particular topic, in the olden days, the musicians used to say inspired by a Western musician or something. Actually, they would have copied the music. But anyway, today what I want to do is that give the credit of this class to my postgraduates from KMC Manipal, because some of the information is from the seminar that was presented by the postgraduates of Manipal on the topic renal disorders in pregnancy. And I'm thankful to these postgraduates. Dr. Priya S. Patil, first year she was that time, now she's second year. And Dr. Deepa Reddy, that time second year, now it's in the final year. And this seminar was moderated by Dr. Rekha Upadhyaya, Associate Professor in KMC Manipal. Thank you, all of you. So I have borrowed, of course, I have taken permission from them to borrow some of their slides and some of their information. This is actual slide, their first slide. Of course, you can make out from the color combination. It's not my color combination. Anyway, before we go into understanding the subject of acute kidney injury in pregnancy, we need to understand the renal physiology and physiological changes that occur in pregnancy. Hemodynamics. There is an increased renal diameter, 1 to 1.5 centimeters. Volume, up to 30% increase. I usually teach undergraduates to simple way of remembering the physiological changes of pregnancy in any system for that matter is everything is increased, because almost everything, barring one or two things, everything else is increased because the mother has to accommodate a guest, that is the fetus. So blood flow is increased by 80%. Obviously, GFR, glomerular filtration rate, is also increased by 50%. As I said, not everything is increased. Some things are decreased as well. There's a decreased plasma osmolarity by 10 mmol per kg. What else? There are changes in tubular function as well as. There is increased glycosuria. There is free leakage of glucose in the urine. That's exactly why we don't respect glycosuria so much in pregnancy as compared to the plasma glucose or blood glucose. Bicarbonaturia, metabolic acidosis, is sometimes almost near normal in pregnancy. Calciuria, everything is leaked because there is increased glomerular filtration rate. Proteinuria, up to 260 milligrams per 24 hours. That's exactly why the definition of preeclampsia is anything more than 300 milligrams is pathologic or significant, because up to 260 is normal in pregnancy. What else? Ureters at every level, kidneys to the tubes and to the ureters. There is dilatation, right more than the left. Bladder, there is muscle hyperplasia. That's why maybe there is increased contractions, and then of course they have increased micturition. Increase in bladder pressure from 8 to 20 centimeter of water. Endocrine functions. There is increased renin, erythropoietin. That's very important to prevent anemia. Active vitamin D. So if I have to put everything in a particular, in single slide, it will go like this. There is structural changes, that is pelvic calcial dilatation, hydronephrosis because of the pressure from the growing uterus, increased GBM pore size contributes to physiological proteinuria. Then there is corpus luteum of the pregnancy, right in the early stages, that would give relaxin and progesterone free of cost and also nitric oxide. They will increase the renal hemodynamics. 50 to 80% increase in RBF, 50% increase in GFR, afferent and efferent arterial vasodilatation. What else? Hypothalamus. There is decreased threshold for vasopressin release. As a result, there will be systemic changes such as decreased sensitivity to RAS, increased water retention, decreased plasma osmolality. Changes in tubular function, increased glycosuria, increased calcium excretion, calciuria, increased glycosaminoglycans, and decreased reabsorption of uric acid. So finally, endocrine function, increased erythropoietin factor release. So that is a function, and increased RAS activity. So in nutshell, you can take a snapshot of this particular slide, which will explain everything about renal changes. So having understood this, let's now go to understand what is pregnancy-related AKI called PRAKI. It's a heterogeneous syndrome defined by rapid decline in the GFR. We have understood that there's an increase in GFR during pregnancy. So here what happens? There's a rapid decline in GFR and abrupt loss of kidney function. When we say acute, it has to be abrupt and rapid. So abrupt loss of kidney function, and there is a rapid decline in GFR. The incidence is luckily less than 10%. Usually the incidences of most of the diseases is 10%. It is less than that. It has decreased from 1 in 3,000 to 1 in 20,000, maybe because of better understanding, better recognition, prevention, and better management. Diagnostic definition of renal diseases during pregnancy is not uniform. Hence, validated definition of PRAKI is not yet established. So we cannot give a clear-cut definition of PRAKI. There are different definitions. General consensus are with KDIGO and rifle. What are these conditions? I will tell you that in the subsequent slides. So definition of PRAKI is urine volume less than 0.5 ml per kg per hour for 6 hours at least. So there is a decrease in urine volume, or increase in serum creatinine by equal to or more than 0.3 milligram per DL within 48 hours. Obviously, the serum creatinine is one of the important indicators to define the renal function and renal health. So an increase equal to or more than 0.3 milligrams per DL within 48 hours. Or increase in serum creatinine to more than 1.5 times, not actually in terms of absolute value, but in a comparative value, more than 1.5 times the baseline, whatever was the baseline, within 7 days. So that is the definition of PRAKI. You have got or 2 times. So any one is good enough for us to diagnose acute kidney injury that is related to pregnancy. Now, based on that, there are different stages. What are these different stages? Stage 1, where serum creatinine is, we started with 1.5 times, if you remember that in the previous slide. 1.5 to 1.9 times baseline, or equal to more than 3 milligrams per DL if you go by the absolute value. That is stage 1. As far as urine output is concerned, less than 0.5 ml per kg per hour for 6 hours. That's the baseline definition. So whatever was told in the previous slide is stage 1. Now, when it is stage 2, obviously you start with 2 to 2.9 times the baseline. As far as urine output is concerned, multiply by 2. 6 into 2 is 12 hours. Urine output is decreased for 12 hours. Stage 3, 3 times. Very easy to remember. 1 is 1.5 to 1.9 because 1 is normal. So it has to be more than 1.5 up to 2. Whereas when you say stage 2, you start with 2 to 2.9. And it is stage 3, means start with 3. 3 times the baseline, or more than 4 milligram if you go by the absolute value, because stage 1 is already 3 per DL increase, or initiation of renal replacement therapy. If you have to start therapy, that means she has already reached stage 3. And as far as urine output is concerned, again multiply 12 by 2. So it becomes 24 hours. You keep on multiplying that, or anuria for more than 12 hours. So these are the different stages of acute kidney injury. So you have understood what is KDIGO, kidney disease global. We are trying to change the global outcomes, improving the global outcomes. Now, let's see what is this rifle as far as PRAKI is concerned. R stands for risk. The GFR criteria, urine output criteria, is taken here. As you can see here, there's increased serum creatinine 1.5 times, or GFR decrease more than 25%. So it's the same as stage 1, if you can see that here, as well as the urine output less than 0.5 ml per kg per hour into 6 hours. This is something like stage 1, the basic definition of AKI. Then you go to the injury level, right? Risk level is over. RI, that is injury level, it is increased. Serum creatinine is increased 2 times. That is stage 2, if you can think there. And GFR decrease is more than 50%. And this side, it is 12 hours, correlating with the stage 2, isn't it? Now, failure, rifle RIF. Here it is 3 times, stage 3. And GFR, it's the increment, 25%, 50%, and 75%. So GFR decrease is more than 75%, or serum creatinine more than 4 grams. Acute rise, 0.5 milligrams per DL. This is all similar. Stage 1, stage 2, stage 3, as you can see here. And the decreased output is more than 24 hours, or anuria up to 12 hours. So all this is same as what we saw in KDIGO. Now comes loss level. There is persistent ARF, that is complete loss of kidney function for more than 4 weeks. Too much. And then end stage kidney disease, ESKD, RFL, just to complete the rifle, E has been added. It is more than 3 months. 4 weeks is 1 month. So this is the down spiral of the kidney injury from acute to chronic and end stage. So the first 3 have got very high sensitivity. This definition, very easy to remember. Output less than 0.5 ml, it's the same, 6 hours, 12 hours, 24 hours. This side, 1.5 to 1.9, 2 to 2.9, and more than 3 creatinine. Loss is loss for 1 month, and end stage is end stage. And this is very highly specific. So I hope the last 3 slides are almost talking the same thing in different language and different definitions. That's all. What are the causes of PRAKI? The causes can be traditionally divided as pre-renal, intrarenal, and post-renal. This, all of us know that. Again, further classification under this is early pregnancy. Now, early pregnancy, what can be the pre-renal cause? It is so easy to just spell out without my lecture, without listening to me. What will cause pre-renal problem? The bleeding, of course. What is causing the bleeding? First trimester miscarriage. Ectopic pregnancy. What is causing the hypovolemia? Hyperemesis gravidum, loss of fluid, dehydration. OHSS. I told you in the OHSS class, the shifting of the intravascular space into the third space. So all of them are giving rise to hypovolemia and give rise to the kidney injury, and they are called pre-renal cause. What is intrarenal? Apla syndrome, sepsis, autoimmune diseases, glomerulonephritis, lupus nephritis, CKD progression. These are all intrarenal causes in the early pregnancy. What is post-renal cause in early pregnancy? Renal stones, ureteral obstruction. So pre-renal, intrarenal, post-renal. Further division is early pregnancy. Next one is obviously late pregnancy. Anybody's guess, very easy guess for even a first year OBG postgraduate. Pre-renal has to be bleeding in the second trimester, miscarriage, placenta previa, abruptio placenta. Intrarenal, almost similar, but now you know that second trimester onwards, there will be severe preeclampsia leading on to HELLP syndrome, acute fulminant liver, acute fulminant AFLP, and HUS, TTP, pyelonephritis, chorioamnionitis. CKD progression will that is already there, and glomerulonephritis. Post-renal, of course, it could be polyhydramnios, which is compressing on the ureters. Twins also, they do the same job, large fibroids towards the later part of pregnancy, ureteral obstruction, and of course, renal stones can be there in any time of pregnancy. Then comes postpartum period. After early pregnancy, late pregnancy, postpartum period. What is the pre-renal cause? Obviously, bleeding due to atonic PPH, traumatic PPH. It could be uterine rupture or vulvovaginal tear or lacerations. Intrarenal, same thing will continue. Severe preeclampsia, HELLP syndrome. Now you can add puerperal sepsis to this. The rest of it is same. Glomerulonephritis, interstitial nephritis. But here, in addition to that, nephrotoxic drugs, because now when she delivers, you would give her painkillers, NSAIDs, antibiotics. CKD progression will always be there. Post-renal, of course, now we have only renal stones as a cause. So now you know the causes, pre-renal, intrarenal, post-renal. Further division is early pregnancy, late pregnancy, and postpartum. Whatever it is the bleeding in the pre-renal situation or hypovolemia, and the kidney diseases in the backdrop of pregnancy conditions like preeclampsia and its complications in the intrarenal arena, and post-renal, there will be stones or compressions due to fibroids and the growing pregnancy and things like that. So let us now look at the timing of PRAKI. What is that? This is the same thing put in a different glass, same wine in a different glass. First trimester, septic abortion, hyperemesis gravidarum, and then second trimester, acute pyelonephritis, preeclampsia is starting there, going for eclampsia, HELLP. Cortical necrosis will start in third trimester, acute fatty liver, fulminant hepatitis, and thrombotic thrombocytopenic purpura, TTP, what is said, and obstruction during delivery, or maybe because of big uterus, polyhydramnios, twins. Postpartum NSAID use, atypical HUS, and glomerulonephritis flare can be there throughout first trimester to second trimester. This is a wonderful slide, and I think I picked this slide from our postgraduates. Thanks once again to them. So here you can see beautiful overlap of the problems across the trimesters and including postpartum period. Wonderful slide. Pathophysiology of PRAKI, pre-renal azotemia, that is due to hyperemesis gravidarum and sepsis. Acute tubular necrosis can be due to hypovolemic states, hyperemesis, preeclampsia, HELLP. Acute cortical necrosis can be seen in abruption, septic abortion, amniotic fluid embolism, and DIC. What is minimal AKI panel that has to be estimated? CBP goes without saying. Peripheral smear will give you an idea whether and it correlates with the amount of hemorrhage. Urea creatinine is a direct evidence of kidney disorder or kidney renal function failure. Urine R&D, routine and examination, microscopic examination. LFT, because you can make out acute fulminant hepatitis. Electrolytes disturbance can be seen in hyperemesis gravidarum and all other causes of hypovolemia. ABG, blood gas analysis has to be done, arterial blood gas analysis, and sonography and MRI to make out both the kidney problems, hydronephrosis, ureteric problems, and of course, the uterine, multiple pregnancy, polyhydramnias, fibroid uterus, and things like that. This is called minimal AKI panel. What are the specific investigations you would like to do? Of course, CBC also comes under specific investigations. There will be decrease in hemoglobin. Hemolysis and GI bleeding also should be considered. Sometimes initial increase in infection, later decrease of WBC. Platelets are decreased and altered in coagulation failures, DIC, thrombocytopenia, microangiopathy, and even in severe preeclampsia, HELP syndrome. Pancytopenia, if there is marrow infiltration or in malignancy complicating pregnancy. Peripheral smear, fragmented RBCs, reticulocytes can be seen. Renal function tests, this I told you, urea is increased and urea creatinine ratio also is increased. Pre-renal AKI, you can see this. Increased in uric acid is specifically seen in preeclampsia. We all know this. Other specific investigations include other biochemistries such as increased potassium. This requires urgent management. All of you know that increased potassium can be very detrimental to the heart. There can be sudden cardiac arrest. Sodium usually is normal, but it is decreased in volume, overload, and diuretics if they are used. There is decrease in HCO3 if there is metabolic acidosis. What about liver function tests? Decrease in albumin implies proteinuria of preeclampsia or other reasons, and GN. Increased bilirubin, HELP syndrome, preeclampsia, hepatorenal syndromes, you will see increase in bilirubin. Hemolysis is the cause of it. Lactates to assess underperfusion and tissue ischemia. C3, C4, usually estimated. You should also estimate this ANA, ANCA, ADMATS 13 levels to see the immunological reasons of kidney injury. Renal function assessment, you can do a routine of urine examination, 24 hours proteinuria if it is more than 300 milligrams. Nowadays, we don't do this. Dipstick 1+, 2+, 3+ correlate very well. Urine protein to creatinine ratio, if it is more than 0.3, serum creatinine persistently more than 0.9 milligrams per DL. Up to 1 is normal, what I said. Sonography, you can see the size, relative consistency, and elements of obstruction, fibroids, other tumors. MRI, you can assess the renal masses, if at all. Now I come to the last part of the talk, that is the management of PRAKI. It is basically three-pronged. Number one is renal function supportive measures. Number two, treatment of underlying disease, whether it is preeclampsia, HELP syndrome, or acute fulminant hepatitis of the pregnancy, HUS, etc. And finally, when kidney has really failed, nothing short of dialysis will help. What is this supportive management? Supporting the kidney functions. It is actually preventive measures. I told you prevent the recognition, prevention, and treatment. Supportive management is nothing but preventive measures. Restore or maintain fluid balance. Hyperemesis gravidarum, give her IV fluids, give her oral fluids. OHSS, I told you, initially oral fluids, later IV fluids. Preeclampsia, plenty of fluid should be taken. So restore or maintain the fluid balance, either oral fluid or by IV fluid. You have to be careful when you give IV fluids in preeclampsia and heart diseases and other situations. Maintenance of electrolyte and acid-base balance. Very, very important, especially in hyperemesis gravidarum, also in shock and other situations. Maintenance of nutritional support. All of you know this. Prevention of infections, the renal disease in the kidney, cortical necrosis, all these things can happen. So you have to treat the infection very aggressively. Consider delivering when there is severe preeclampsia, when there is acute fulminant hepatitis, and sometimes even in abruption, you have to deliver. There's nothing short of delivery that will cure this problem and prevent acute kidney injury. Avoid nephrotoxic drugs. I already gave you the list of drugs that can be nephrotoxic. Control continuing blood loss. Very, very vital, both from the point of prevention of acute kidney injury as well as saving the patient's life. Avoid diuretics unless there is volume overload. Otherwise, it will be like, you are beating an already tired horse. The renal shutdown is not because of the problem. It is because there is pre-renal failure. If you give diuretics, then there will be further insult on the kidney. So you have to be very judicious in using the diuretics. Now, what is this fluid therapy? In initial hours of hypovolemia or sepsis, I told you about the fluid therapy. Fluid of choice given in boluses, ringer lactate, is better. Colloids have limited role. In PPH, 1 liter in first 10 to 15 minutes. I remember very well, there used to be a very famous anesthetist in Manipal. I was a postgraduate, and he used to always make fun of OBG postgraduates, and he used to pull the legs of others also. He used to say these OBG specialists will never understand about the fluids and everything. So when we used to ask him, he used to say, give ADF. What is ADF? He used to say any damn fluid, if you can't understand. So fluid therapy is very important. Of course, now we understand better electrolytes, colloids, and other things we understand. But 1 liter of fluid in the first 10 to 15 minutes is very, very vital. In sepsis, 30 ml per kg body weight as initial fluid challenge in 3 hours. In mild CHF, 500 ml bolus. In severe CHF, 250 ml bolus. Vasopressors, if mean arterial pressure is less than 65 millimeters of mercury, even after fluids. Blood products only if indicated, especially if she has gone into DIC, then you require blood products. Second prong of management is specific management of the underlying disease. What is that? In preeclampsia, correct hypoperfusion, control hypertension, deliver if worsening of renal function. Very clear and very specific. If there is HELP syndrome, control hypertension and deliver. Nothing short of that. AFLP. AKI in 60% of the cases. Delivery is the answer. Acute fulminant hepatitis of pregnancy. There is nothing short of delivery. Of course, you have to simultaneously correct coagulopathy. Pyelonephritis, you have to use injectable antibiotics and volume resuscitation. Placenta previa accreta, give fluids, blood and blood products, resuscitate. If required, go ahead with hysterectomy whenever there is percreta and increta. Abruption, active management, that's what we say. You have to deliver. There's nothing like conservative management for abruption. Simultaneously, you have to give blood, resuscitate her, and correct coagulopathy. We used to say famous 3 things: active management, adequate blood transfusion, and accelerate the labor by ARM. Or nowadays, if the baby is alive and whether in distress or not, most of us prefer to do immediate cesarean section, irrespective of gestational age. PPH, fluid, blood, resuscitation, and surgical management of PPH. At any cost, you cannot allow her to go into shock and hypovolemia. Sepsis, it could be because of chorioamnionitis, septic abortion, puerperal sepsis. I will take another class on sepsis some other day, and there I will teach in detail about sepsis, but suffice to say today, you have to use antibiotics, remove septic foci at the earliest. TTP, HAS, neurological symptoms may be there, TTP, ARF, HAS, supportive care, plasmapheresis is important. Finally, the third leg of the treatment is dialysis. I learned this again from my PGs. It was I get impressed when the PGs do very well, and I tell them, and I request them to share their slides with me. That's the advantage of being in a medical college where there is post-graduation. You can learn from the postgraduates, especially the postgraduates who are very, very meticulous. They read and come and they do such wonderful seminars. Thank you once again, Dr. Priya Patil and Deepa Reddy. AEIOU, very easy to remember. What is A? Acidosis, metabolic, refractory to medical management. Go for dialysis. The second A is if there's anuria, renal shutdown, dialysis is the only way. E, electrolytes, intractable hyperkalemia, more than 6.5 milliequivalent per liter. Nothing short of dialysis will help it. Intoxications, acute poisoning, you have to remove all the poison. The only way to do that is dialysis. Overload, volume overload, non-responsive to diuretic therapy, go for dialysis. Last, uremia, symptomatic, giving us pericarditis, encephalopathy, or neuropathy. Dialysis is the best answer. So AEIOU, acidosis, anuria, electrolytes, intoxications, overload, and uremia. Thank you very much for your patient listening. And tomorrow, let's have one more topic. And see you all tomorrow. Thank you very much.